Welcome to another episode of Single Payer Radio. We broadcast our program from the historic Hayburn Building here in downtown Louisville. The show is a project of Kentuckians for Single Payer Healthcare, and we're an affiliate of the Kentucky chapter of Physicians for a National Health Program. For listeners who aren't familiar with our program and the state of affairs with our healthcare system, I just want to remind folks that we pay twice as much for our care here in this country and get worse results. And we have over 100 million people in this country carrying medical debt, which problems facing eviction, foreclosures, food insecurity, and more bad health outcomes. That's why we advocate for a national, publicly funded, nonprofit, single-payer system. Everybody in, nobody out. The views and opinions expressed on our show are those of the speakers and not the station. I'm Mark McKinley, a volunteer with the station. Single-payer radio can be heard on WFMP LP 1065 on Mondays at 2 p.m., Tuesdays at 7 a.m., and Wednesdays at 11 a.m. You can also live stream our program, and if you miss a show, you can go to our archives at forwardradio.org. WFMP is an all-volunteer station. We rely on the community for your ideas and our funding. I want to welcome our guest to this week's episode, Dr. Garrett Adams. Those familiar with single payer here in Kentucky and the Kentuckians for Single Payer Healthcare know that Dr. Adams is a pediatrician, places Vanderbilt, Wake Forest, retired full-time faculty at U of L School of Medicine. He was the founder, and this is something that we'll be going into more detail today. In 2010, Garrett established the Beersheba Springs Medical Clinic. Garrett is also past national president of Physicians for a National Health Program. And Dr. Mike Imburgia is a cardiologist in the Louisville area and founder with his wife and longtime friend of the Have a Heart Clinic here in Louisville. He established that in 2008, where he is the medical director. Dr. Imburgia received his medical degree from Southern Illinois School of Medicine and has been in practice for more than 20 years. On today's episode, Garrett and Mike will be discussing their clinics and the issues of access to care and health equity. And I guess we want to start off with a question. What year in medical school did you learn how to establish a health clinic? Mike?
They don't spend a lot of time on that. So you just kind of pick it up on your own.
Okay. Garrett, how about you?
I think that's a great question. I love that question.
when you started your career, did you have any idea that you would be establishing a clinic, or there would be the need that there is there in Beersheba and other areas about establishing clinics to take care of folks?
The closest I came to it was my mother brainwashed me with reading certain books. And when I was little, I thought I wanted to be a doctor and live on a farm or live in the country. So that was probably maybe a little bit of seed of ambition, but it really didn't come into reality until many years later.
Okay, good deal. And if you all could discuss your clinics, it seems like you see the need because it's folks are going without care. And you've got two different models. Garrett is in a more rural community, like you're here in downtown Louisville. Mike, can you talk about how you came to establish this and give us the view, the macro on what's going on there?
Sure. So, and it started out of just a desire to give people without insurance access to cardiovascular care. And so the story is, through a bizarre chain of events, it led to this foundation, and my wife came up with the catchy name, Have a Heart Clinic, and we were going to focus just on cardiovascular care for the uninsured. And we used our existing office, which is in the east end of town, and we do a Saturday a month. It got so busy, we started doing a Saturday and an evening a month, and then we kind of realized we were so far removed from the population we were seeing, and a lot of people don't understand that for these underserved populations, to get to clinics is not easy to do, especially specialty clinics. So there's pretty good representation from federally qualified clinics and other non-for-profit clinics for primary care, but there really is difficulty for specialty care. And I think the statistic is about 40% of all primary care visits are for some type of cardiovascular issue, whether that be hypertension or chest pain or shortness of breath or whatever. And then, so we realized we were so far removed, so we went on this mission to be closer to them. And so in 2017, we moved our clinic space in on East Broadway, just about 4 or 5 blocks from here, and right on an east and westbound bus stop on Broadway, so we could give better access for those patients. And the first focus was just access to care. How do we give direct access for federally qualified clinics and other non-for-profits? And so we started doing that, and we were able to fulfill that need. And I went part-time at my old job about 4 years ago, and then I quit my job and I volunteer full-time now at that clinic 5 days a week. And but then we moved on from that and said, okay, we're giving people access, but that's not just the problem. It's how do you keep people healthy from developing cardiovascular disease, which is the difference between us and other countries. It is not just equal access to care, but how they spend their healthcare dollars and preventing illness as opposed to just treating illness. And so we started doing community screenings. We go to various churches, various clinics, and we would check their cholesterols, their blood pressure, their heart rhythm, their abdominal aortas. We were doing carotid ultrasounds, and then trying to refer those people back to better care to try to get them living a healthy lifestyle and try to keep them healthy. And we set up a health equity center in our clinic where we have a nurse, a psychologist. Well, we just do a lot of education. So the focus first was to give access to health care for everybody, and then to now how do we help prevent disease. And if you live at or below the 200% federal poverty level, which over 50% of our country lives at that level, we provide free care. So even if you have insurance, you don't pay us deductibles or copays. And that's about 85% of the people that we see pay us absolutely nothing.
Fantastic. Garrett, how did they start in Beersheba, and how did they unfold, and what's happening there?
Yeah, well, first I'd like to respond to Mike's presentation, Mark. I think that's fabulous what you've done there, Mike. It's really
Thank you.
Amazing. And I'm remiss in not knowing about you and what you have done and are doing. Our situation is very different from yours. And it has to do with primary care and providing primary care to an underserved population in the mountains of Tennessee on the Cumberland Plateau. There's the community, and Mark has actually visited us there, and it's called Beersheba Springs. It's in Grundy County, Tennessee. And when we started our clan in 2010, Grundy County was the poorest county of, I'm thinking how many counties, I think 92 counties in Tennessee, or 95 maybe. And the poorest county with the poorest health outcomes. So we had a lot of work to do. My wife and I bought a house there, and it so happened that my grandchildren are the sixth generation in my family who have been going to Beersheba Springs in the summertime. So it was created before the Civil War, or founded, Beersheba was, in about 1833, and was a popular resort when folks in the big cities were trying to get away from cholera and typhoid epidemics. They would come in the summer, and was advertised. It was as a resort. It was advertised in these big cities. So that was my great grandfather took his children up there to avoid a cholera outbreak in Nashville. And that's how I happened to get there through the family connection. I got to, my wife and I got to know the mountain people. And one day, a friend of ours, a close friend named Josephine, came over to the house, and we were sitting on the front porch, and she wanted me to see her face. Her right side of her face was like a baseball. It was swollen and red and inflamed. It was obvious that she had an acute case of cellulitis. It was really a dangerous situation medically. And so I told her, I said, Josephine, you got to get some medical care right now. And she did. But she wound up with, and she got better, but she was stuck with a $2,300 bill for some care that she got at a for-profit hospital about 40 minutes from Beersheba, which I thought was really unreasonable and unfair. We later went down with her to the hospital and talked to the administrative person who had to do with billing, and she's sitting there and says, "Oh, so it's self-pay." Well, then she goes on the computer and lowers the price. And then we said, well, what if we pay now? And she goes da 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 on the computer and lowers the price again. So that was helpful. But when I got home, I just determined that we needed to do something to help these people. So I got together with a friend of mine who knew the local people well. He'd been a commissioner on the city council, and we got a group of community leaders, and we began to talk about how we could develop a clinic. And so that was how we how we got started. The first thing we did, though, was to make an inventory of what healthcare was available to the community. A very small community at that time was just 450 people, and but we thought that we would try to serve that community, and it would be a clinic of, for, and by the community of Berkshire Springs. Well, it turned out from our inventory that there was healthcare available, but it was not affordable, and our people just couldn't afford it. So finance was really the stumbling block. So we determined that we would set it up, and it would be free and not for profit, and that we determined we would not use insurance, and we would not have any corporate funding or federal or state funding. So how did we finance it? Cousin of mine was wealthy, and he said, "How much do you think you need?" I said, "Well, probably 250,000." He said, "I'll match you 125." And so that's how we got started. And then we were able to, with private donations, able to keep it going. And that's kind of how we got started.
Okay.
Let Mike go on.
Wow. Mike, how about you and your clinic down there as far as the staffing? How many staff do you have, the reliance on volunteer professionals, and your collaboration with other groups here in the community? And have you seen the need grow? Is it a result of more people finding out about you, or that need has always been there and just increasing?
Yeah, I mean, great questions. And so there's a lot of answers. 90% of the people we see come from either federally qualified clinics or other non-for-profit clinics.
Okay.
And we deal with kind of a different population. I mean, we deal with marginalized communities in Louisville, which means that they could be uninsured, underinsured, much like what Garrett's talking about. But there's such a lack of trust in those populations that getting them is hard. And once you get them, convincing them that you really care and you're not there for the money is another difficult thing. And it's not just being uninsured, because of course these things are all intertwined, right? If you're poor, you're more likely to be underinsured or uninsured. If you're Black, Hispanic, you're more likely to be underinsured, or uninsured. And so they're all kind of intertwined together. And so that became our population. And being a consultant, the places to go were first the federally qualified clinics, because again, they provide great access for primary care, but they don't have access to specialty care. So they, when I was part of the Baptist system, if a primary care doctor there wanted to refer to a consultant, they just put an order in and boom, they go to a consultant. Those clinics literally have to go down a list to try to find somebody willing to take their patient. And so you can imagine, if you're uninsured, nobody wants to see you. If you have Medicaid, they're less likely to want to see you. So they really can't get people in. And so that was what we focused on. And the reason why we started seeing insurance is we knew it wasn't going to be a burden on the patients we saw, because it was still giving access to people that didn't have access. And we felt that we could use the money from insurance to help pay for expansion of the clinic. And we've been able to do that. Now we're open 5 days a week, and we do all kinds of cardiac testing, and our staff is often hard to keep because we can't afford to pay benefits and such. But We have probably close to 10 kind of full-time people, part-time, full-time people that work there. That include people that work up front, nurses, sonographers. In our health equity center, we have a nurse navigator and a psychologist that we partnered with U of L to provide. And so we make ends meet because we don't generate enough to do that. So we make ends meet by applying for grants, and a lot of the money we get is personal donations to keep the clinic running. And we've been able to kind of limp along pretty good. And then to get to your question about the need, is, when you're doing one weekend a month, which we still do one weekend and one evening, and those are all volunteer clinics, so no staff, it's all volunteer. And I got to tell you, it's an incredibly joyous day because I always tell people, imagine a clinic as a patient that you go to that everybody's really truly there just because they want to be there to help, and it's an overwhelming feeling. And the same thing's true of the screenings we do. But so when I went part-time and we opened up the clinic 2 days a week, we were quickly booked up. Now that we're there 5 days a week, and we just had one of the hospitals, Baptist, who donated a nurse practitioner to us almost a year ago, and now we're there 5 days and a nurse practitioner. We're booked out almost to January. So I think it's a testament to a good job that we do and that we care and people know that. But I think it's also a testament to the fact that people don't understand the need these people have out there, that they don't have the same access as everybody else. And the fact that the clinic could be booked up that quickly in that short period of time, I think is more of a testament to the incredible need out there in the public for that care.
And just want to touch base on something before we switch back over to Garrett. Now, I saw on your website that you're dealing with populations that English is not their first language.
Yes.
And working through that, it's I did see that you all got some funding for somebody who can give you a hand with that. How's that? And I just know that I worked part-time for a friend of mine who does great work on restoring box gutters, etc., on and that part of the trades. But he had 2 Guatemalan women, and a guy from Guatemala, and a great carpenter from Mexico. And just the language barrier of trying to operate on a website. Had one person who had decent English skills, but just the translation portion of trying to get through the day. How's that?
Yeah, so there's tons of studies that show that those people that don't speak English are at an extreme health care disadvantage. And 20% of the people we see don't speak English. 18% of the people we see speak Spanish only. And so we've gotten grants for interpretation services, and we've hired a couple of bilingual people to work up front and help us with interpretation skills. We've even funded people to go off and get certified as Spanish interpreters because there's such a large population. And again, that's I think something that the public doesn't understand, that even if you immigrate to this country legally, if you're not a refugee and can get health care in a different manner, you're not eligible for healthcare coverage here for 5 years, which means we say, welcome to our country. We're going to give you the lowest paying job. You're not going to be able to afford health insurance. Oh, and by the way, we're not going to take care of you either. We're not even going to let you get subsidized health care. And so that's a large number of our patients come from those populations. The Family Community Clinic at St. Joe's here in town does a huge Hispanic population that refer to us. And so that's kind of how we meet the need. And there's a special group. I mean, you have to spend more time, and most people don't have the time or take the time that we do. And it just is certainly more involved, but a big need that needed to be taken care of.
Jared, I read that you've got a new executive director at the clinic there.
Right, right. Thank you.
And that you guys offer classes and was it kind of focused on diabetics, diabetes, and
Yeah,
and
this
some of
this
the
will be
other things.
our second year or third year of providing a diabetes class for individuals who have diabetes. Diabetes is one of the most common diseases that we're seeing. Excuse me. And of course, there's cardiovascular disease and hypertension especially. But the diabetes education has been very helpful. And I had an interesting patient that was kind of a surprise. Let's see if I can find this. This was a woman who had came in at blood sugar of 500. Blood sugar really shouldn't be over, what is it, Mike, 125 or something like that. And she was 500. And the reason she had a glucometer, but she didn't have any strips. She couldn't afford the strips to measure her sugar. The new director is just a godsend. The one we had before graduated to a better job. This one I think is going to stay. Early on, and Mike will understand this, I was the primary provider, but we had a physician's assistant who turned out to be a fantastic person. She's the best clinician, overall clinician that I've ever worked with. And she and I did the medical aspects, and I was the medical director and was supposed to sign 20% of the charts. And we had somebody in the front office, office manager. I was the first president of the board. I was the medical director, and I was the executive director. And so I was doing 3 jobs, and it was pretty busy. Now we have a really great executive director who has past experience, and she's going to fit in real well. Keeping the staff is a problem, but we really fell into an interesting thing. We had, I'm trying to think how Nick first came. We had a resident from Yale. I know what it was. He met. There was a connection we had between the University of the South, Sewanee. There was a graduate from the University of the South who was part of the Yale Child Study Center, and she met a person on the staff or knew a person on the staff at Yale, and we got to have a resident come down and spend a couple of weeks. And he had so much fun, he wanted to keep coming. And then we got some more residents, and so we had a situation where we have had several residents from Yale, and Nick was enjoyed it so much that he got a job at Erlanger Hospital in Chattanooga if they would allow him Fridays to work at the Beersheba Clinic. And he came and brought his wife, who's a pulmonologist, and so he's coming up to the clinic, and he's now our assistant medical director. And the other one is a primary physician in Murfreesboro who is there frequently. We are open. We're proud to have just added a third day. We were just Monday and Friday, and then we were able to, or Monday and Wednesday, excuse me. But and then we were able to, when Nick came, we were able to add Friday. And then we have another young physician who's an ID doc, infectious diseases at Baptist Hospital in Nashville. So we have those two young physicians who are there a lot, and we're still getting residents from Yale. We've had some residents from Meharry in Nashville, and it just thrills me to be able to have these contacts with the local medical centers. Another fortunate circumstance was there's a hospital about 25 miles from Beersheba in McMinnville, Tennessee, that's connected with St. Thomas in Nashville, or the Ascension Group, and they have agreed to give us imaging services. So our patients can go there for imaging services and free. And so that's been great.
Fantastic. Let me shift back over to Mike. Mike, you mentioned a health equity center. Is that, you say, a relationship with U of L, University of Louisville, or what is that, and how does that work with your practice?
So again, in our communities, they've been marginalized for so long. There's just this lack of trust, and they just don't understand, nor do they have the resources to be healthy and to live healthy. And there's thousands of studies, and it's not new. It's been around forever, where there's disparities in healthcare based on race, ethnicity, income, insurance status. And so we kind of set it up just to make sure that everybody got treated equally and that everybody had the same outcomes. And so we track things back there, like, was their blood pressure a goal? Are they on the right cholesterol medicine? If they have coronary artery disease or heart failure or atrial fibrillation, are they on the right medicine? And make sure that we're not treating one population different than the other. And it's just a lot of education. And a lot of the other issues is, if you're not healthy psychologically, you're not going to be healthy physically. And so we formed a partnership with U of L's, one of their departments of psychology, their Cardinal Success Program, it's called. So we have a psychologist in our clinic 2 days a week that the patients will refer there, have an opportunity to meet with them. But I mean, we have a lot of other relationships, like I said, the Fairly Qualified clinics, we have a close relationship with, and U of L Medical School, we usually have a fair number of medical students that come through. We do some nurse practitioner training with Spalding University, and then other connections that you need in our population, which is housing and food source. So there's an entity called New Directions, Housing.
I used to work there.
Fabulous organization. And so starting November, we're doing one screening a month at one of their facilities
Mhm.
to try to capture people there and try to get them healthy. You know, again, and this is off topic, but you know, as you said in the beginning, we spend more money on healthcare with worse outcomes. But there's a great book, and you probably read it, Upstream, and but it talks about that. That's kind of a little bit of a misnomer. It's how we spend our healthcare dollars. Other countries spend $2 preventing a problem for every dollar they spend treating it. We here spend $2 treating it, and we barely spend a dollar to prevent it. And so that's part of what our focus and vision is also going forward. And I would say that's probably what more of the Health Equity Center is, to do that, to partner with places to how do we keep communities as a whole healthy.
And just another question about, do you all go down to Churchill Downs
We do.
to work with the community there?
Yeah.
And you're working primarily with adults, correct?
Yes, that's all. We
Okay.
only do adult
Okay.
cardiology.
Okay.
Yeah. So we do, you know, I'm doing a lot of shout outs here because there are a lot of incredible organizations out there doing unbelievable work. And so the Kentucky Racing Association has this fund where all unclaimed wagers, they put in this fund to care for the people that don't have anything on the backside, a church, education, and healthcare. And they have two kind of health fairs every year for them, one in the spring and one in the fall. And so we've been going to those, and we'll do screening there. In fact, we just did that last weekend. No, last Monday, a week ago, we did it. We screened almost 40 people there, which, you know, again, you'd be shocked at how bad the data is. And probably 60% of the people we screened there had high blood pressure and didn't know they had high blood pressure. And so those people, now you can move on to their clinic, which they provide a clinic for those people, and get them treated and healthy.
Garrett, with the folks that your staff sees in Ursula Springs, rural community, what is there like if it's a more rural community, are there farming accidents, or what do you guys see up there? And I also read something that you've started a dental clinic down
Yeah. That was one of my dreams early on. I had several dreams that could happen. One was affiliation with universities, and that's come to pass, and a dental clinic. I told you that I signed 20% of the charts that the physician's assistant sees. And we had two physician's assistants when I was most active at the clinic. And I was signing these charts, and I signed one that was for a patient with a dental abscess. And then I went to the next chart, dental abscess, dental abscess, dental abscess. The 5 straight charts was dental abscess. And so I really couldn't imagine how common dental problems, serious dental problems, were on the mountain. Met a dentist who was retiring over in Sewanee, and he was interested in working with us. And by George, he came over and started a clinic with us. And we, about this time, there was a little house next door. Our clinic was a a mobile home that manufactured housing that we remodeled into a clinic, and we had volunteer help in getting that remodeling done. And then there was this little house next door that was affiliated with the church, and the church owned the house. The house was between the clinic and the church, and the church gave us the house, and we made a clinic there. And so now we have a dental clinic, but we don't have a hygienist, and so we really can't do anything now but extractions. But here's another cooperative venture. We have a dentist who had family, kind of like me, had family at Beersheba. He was on the faculty at the University of Alabama Dental School, and he has come up and is helping with extending the dental work. The retired dentist from Sewanee had to give up the extractions because he got arthritis in his wrists, and he just couldn't do it. But we've got this other guy. So, we have contacts at the University of Alabama, Meharry in Nashville, Vanderbilt, Baptist Hospital in Nashville. We don't have a direct affiliation with Vanderbilt, although we do send a lot of patients there. And and Erlanger Hospital in Chattanooga.
Garrett, what happens in these communities that don't have your connections and your passion to bring healthcare to folks who can't afford it?
Okay, you've asked the same question that Bernie Sanders asked. That was in 2000. And Bernie was on this committee. It was called, and he held a hearing, and the title of his hearing was, "Is Poverty a Death Sentence?" And he asked me to testify, and I testified in Washington in the Senate. And I just told him about a few of the patients, and I'll tell you about them. This is a woman, Charlotte Dykes, had an obstruction, and you'll be interested in this one, Mike, to the main intestinal artery with stent placement in Chattanooga. We diagnosed a severe blockage of the main artery in her right arm and a 70% carotid artery blockage. We have a volunteer physician who, ever since we opened the clinic, when he heard, he's a radiologist, and when he heard it back in 2010 that we were going to open a clinic, he went out and got himself an ultrasound machine to use in the clinic, and he comes up periodically and does ultrasounds. But in this Charlotte's case, the surgeon would not operate unless she paid up front, because she still hadn't paid her bill from the previous surgery. So she's a walking time bomb. And when I wrote this, she was going to be 65 in December when she'd be eligible for Medicare if she lives that long. And she gave me, I asked her if I could tell her story, and she said, "You speak out for me." And then at the time of the hearing, I was pleased to report that she had reached 65 and had an appointment with a vascular surgeon for evaluation and treatment of her artery blockages. So we see people between age 19 and 65. When they're 65, they have Medicare, and when they're below 19, up from birth to 18, they have TennCare. But Governor Lee of Tennessee did not expand Medicaid. So he's, a lot of these people were hurt that way. We had a woman, 54 years old, hadn't seen a doctor in over 20 years. And we diagnosed she had an acute heart attack. She was airlifted to Nashville, treated and discharged, but she didn't fill her discharge prescriptions, including Plavix, and didn't go to cardiac rehab because she couldn't afford it either. She was doing poorly and had a recent dementia due to small strokes. Here's Doris, 58, and her husband operated a small local restaurant before her illness forced them to close the restaurant. Estimated annual income was $13,000. No insurance, no medical care. She heard we offered free mammograms and we diagnosed the breast cancer. It goes on and on, but that's what happens.
Yeah.
And the other thing is, not only is poverty a death sentence, but illness is a poverty sentence.
Mike, what would you tell people if you operated if you were the editor for a newspaper that ran medical columns? I mean, what's not being shared through our corporate media about what's going on here on the ground that you're seeing? That it's like, where is the outrage about some of these things?
Yeah, I think Garrett touched on the important things, and it's not just poverty, it's race, and it's people like to blame it on social determinants of health, but again, these things are also intertwined. If you're poor, you're more likely to suffer from social determinants of health. If you're Black or Hispanic, you're more likely to suffer from social determinants of health. It's not genetics to grow up poor. It's not genetics to live in poor neighborhoods. Through years and years of implicit bias, racism, we push populations to those areas, and consequently, they're poor. And poverty is not just race. I mean, there's plenty of poor white people out there. It's endemic. It's everywhere, and they don't have access. And I think the normal. First off, it's ridiculous to think that people can live off of $700-800 a month and be able to have health insurance. It's ridiculous to think they can live off $2,000 a month, $3,000 a month, and be able to afford health care for their families, because they can't. And those people don't end up having access to care, which is the number one reason why we have the worst performing healthcare system in the world, is because our people don't have access to care. And statistics like the Louisville Health Equity Report are the things that I like to point out that the public needs to know, but we don't talk about it. I mean, in Louisville, there was a 2017 one, and there was then a 2021 one, but it's not like the media is out there talking about it. But in parts of our community here, the West End and the South End, it's not just the West End. The average life expectancy is 68. But if you go east, the average life expectancy is over 80. And of course, people instantly go to the fact that, okay, fine, it's drugs, it's alcohol, it's violence, that's the problem, but it's not. The problem is they die at 2 times the rate of diabetes, heart disease, hypertension, kidney failure. That's the reason. And if there was better access to healthy living, if there was better access to health care, we could narrow those. But I just can't imagine that our population would be satisfied with people living 10, 15 years shorter lives just because they don't have access to good health care. But yet we don't talk about it. We always talk. I'm rambling, so stop me. But I get pretty upset and passionate about it.
Of course.
We how can we accept that? How can we accept that it's okay for people to live 10 years shorter lives? And how much is 10 years of your life to you? And yet we allow it to happen. And we talk about we can't afford it. Well, how the hell can you not afford it? And we pay for it anyhow. It's not like it doesn't cost us money to take care of the uninsured people. It's not like it doesn't cost us more when people are unhealthy. Of course it does. It costs us a lot more. But more importantly, from the human side of it, the moral, ethical side of it, how do we allow people to live shorter, less healthy lives when we know that there are things that we could do to prevent it? And if the people making the decisions were on that side of the population, would they really allow it to happen? And I don't think they would. I think they would do something to change it. Sorry for rambling.
No ramble. I mean, I'm not going to dispute what you're saying.
Yeah.
And Kentuckians for Single Payer Healthcare, with Physicians for National Health Insurance, or for a National Health Plan Kentucky, we've organized events. We've organized citizen hearings. And somehow the media can cover, well, we found this lost puppy, but it's the exception as opposed to the rule why there can't be coverage for this. And I don't want to rant and ramble. I'm just saying that I've been involved with the group almost 20 years, and we just got to keep plugging along, and the group has decided that this radio program is important and that we're going to devote resources to this. And which is, we're all volunteers. So those are the resources, people power. And, with, it was last week that Governor Beshear expanded dental, hearing, and vision coverage to about 900,000 Medicaid recipients. But the issue is we change governors, and the next governor can come in and pull that rug out from under people. With what Garrett's talking about, you live on one side of the Tennessee line, you're not covered. You live on the other side, and isn't true.
I think though, if people really knew, I think they would do something. But I think the average person doesn't know the disparity.
Garrett,
well, we've been trying to illuminate that difference and the disparity, Mike, and your comments on it. I do want to make a little aside that was exciting for me. I went into the clinic. I don't go down to the clinic much anymore. It's about a 4.5 to 5 hour drive for us. But I've seen we've had some African Americans in the clinic, providers, and it's really exciting. And we've had several, and I think it's been good for the community. This Mercer Springs is, I don't believe there's, if there's an African American there, I've never seen her. But we did have some providers from, there was one from Meharry, and then there was a woman or a couple of women from Yale. So that's nice. And I'm sure our people accepted them and appreciated them. I just wanted to see that, comment on that. So that was a little bit of leavening the bread down there.
Yes, most definitely. And Garrett, I don't mean to be a buzzkill, but it is so frustrating when we have the resources in this country to address these issues and they get privatization of Medicare and other provider. It's discouraging. We're going to be wrapping it up here in a couple of minutes. Any final thoughts from you all? Just really appreciate your time this morning. We're recording this on Monday, October 24th.
Well, it's a pleasure to be here. Nice meeting you both.
You too. I'm glad to hear about your work, Mike. It's terrific. Really, really wonderful.
Thank you. The one thing I've learned about this journey is there are a lot of groups and people out there trying to do good and do the right thing.
Yeah, most definitely. I mean, your website identifies so many of those collaborations that you have and the volunteers that come in to help address this. I just want to say that for folks who want to learn more about Kentuckians for Single Payer Healthcare, you can go to kyhealthcare.org, kyhealthcare.org. Kay Tillo, our chairperson, if you have ideas or would like an invitation to our Zoom meetings that we have twice a month, you can reach out to Kay directly. Her email address is nursenpo@aol.com, nursenpo@aol.com. Mike, you want to tell people how they can contact you or your clinic with the best website or number?
They can contact us at haveaheartclinic.org. Our phone number is 502-245-0002. So whether you're somebody who wants to volunteer or a patient, we'd love to have you.
Good deal. Gary?
Yes, we have a website, and you can find everything that I've said there better. Beersheba, that's BEERSHEBA clinic.org. Beersheba Clinic, all one word, .org. Thanks, Mark.
Okay, good deal. And talk about shout outs. I want to give a shout out to one of my former employers, Project Warm. They are having the Blitz season coming up here soon. They'll have what's called a drive-through Blitz on Saturday, November the 5th. And then they'll do a mini Blitz where they'll send teams out to homes to provide some first line weatherization services. You can always contact Project Warm to if you have drafty windows, doors, things like that, they'd be glad to help you. You can contact the program manager over there at Courtney@projectwarm.org. That's Courtney@projectwarm.org. And the number there at Project Warm is 636-9276. 636-WARM. Fantastic, guys. And for Single Payer Radio, I'm Mark McKinley. Have a good week. Thanks for listening.